The differential diagnosis for tremors includes Parkinsonism, benign essential tremor, alcohol, chronic liver disease, cerebellar problems, hyperthyroidism, Parkinson plus syndromes like Lewy body dementia, and certain drugs like lithium. If a patient comes with a history of tremor, we have to ask for the duration, whether it's at rest or on reaching out for something, whether it involves the head and the trunk as well, whether it's unilateral or bilateral, whether it's intermittent or continuous. Then we ask a history regarding the tone, whether there is any tightness in the limbs. We ask for the gait, whether there's difficulty in initiating movement, difficulty in stopping, and a tendency to fall. We ask for the mood, whether there has been any depression. We ask for a history of weight loss and palpitations in case we suspect thyrotoxicosis. We ask for a history of stroke and weakness in any limb, now or in the past, to include Parkinson's plus in our differential diagnosis. We ask for a history of chronic alcoholism, a history of jaundice, abdominal distension, hematemesis, or melena for a history suggestive of chronic liver disease, and a history of drug intake like lithium, which induces tremors. A family history is usually positive in benign essential tremors, and a history of visual hallucinations would indicate Lewy body dementia.
So for tremors examination, first of all, we have to look at the general condition of the patient, look at the general appearance, whether there's any cachexia, patient is overweight, look at the posture of the patient, if there's any stooping posture, how the patient is looking, any depressed look, then or mask-like faces. Then we look at the nails coming over to the fingers and the nails. We look at if there's any clubbing, any thyroid acropathy at the fingers. We look at the hands, whether it's a fine tremor or a coarse tremor. We can accentuate it by putting a paper on top of the hands to see if any fine tremor can get exacerbated, fine resting tremor. Then we can ask the patient to lift up the hands, cock their wrists back, and see if there's any flapping tremors. Asterisk is for carbon dioxide retention, chronic liver disease, or anything like that, like a coarse asterisk is okay, which is seen in those conditions. Then we can go. We can look at the vitals of the patient, the pulse, if there's any atrial fibrillation in case of hyperthyroidism, and we can look at the vitals there and then, the blood pressure, the temperature, respiration, and blood pressure, pulse rate. Then we'll go on to the face. So in the face, we look at the expression of the face, the voice of the patient, if there's any tremulousness in the voice, or if there's any hoarseness in the voice for hypothyroidism. Then we look at hypomimia, like mask-like faces for Parkinson's. We look at the eyes. We look at the lid, if there's any lid retraction, any lid lag, any exophthalmos, any bilateral proptosis, basically exophthalmos, we can look from behind the patient. And then we look at if there's any titubation of the head nodding movement. Okay. Then we look at the coming over to the thyroid gland. We see a butterfly-shaped gland in front of the neck. If there is enlargement, if it's diffuse, if it is any particular enlargement. So thyroid exam on inspection we can ask the patient to take a sip of water and swallow it. If there's any movement, we can see we're not expecting thyroglossus cyst here. Then we can also feel for cervical lymphadenopathy there and then we can go on to doing specific tests in the face. So first of all, we can do glabellar tapping on top of the glabella and look for the blinking, and after some time it should blink. Then we can do upper limb examination. We can ask them to stretch out their hands in front of them and look for pronator drift here, and also look for the rebound phenomenon. You tell the patient to keep their hands steady while you push it down and ask them to keep it back steady up. So in rebound it can go up. If the patient can walk, we'll ask the patient to do a gait. We'll do a gait assessment with even tandem gait. Then we can ask the patient we can do a pull test. We can pull the patient back and ask them to take a few steps backward to correct themselves, but they will not be able to do this in Parkinson's. We look at the type of gait that they have. So if they have a broad-based gait, or ataxic gait, or depending on whether they have a cerebral disease, or if they have a festinated gait, or a stooping posture, decreased arms swing gait with a difficulty to start and difficulty to stop, it is probably in Parkinson's, and very slow step shuffling gait. So that is for gait. Then after that, we can ask the patient to do a Romberg's test standing at the spot and with the hands by their side, and we're going to hold them on either side, making sure that they do not fall. And we can even look for truncal ataxia when they get up from sitting position with their arms crossed across their hands. Okay. Then I'm going to do some specific tests for the hands, which is tapping the finger and thumb together repetitively. They can do that, or they can do twiddling, they can do piano playing, pretend piano playing, and they can write with a pen. Apart from that, I'll do the tone of the upper limbs, look for cogwheel rigidity, clasp knife spasticity in the wrists, in the elbows. I'll ask them to leave it loose, and I'll do reflexes as well. Then I'll do finger nose finger test. I'll do dysdiadochokinesia, repetitive alternating movements in both the hands. And then I'll also do eye movements and ask for any diplopia. I should have done that along with the face. But eye movement for looking for ophthalmoplegia, and ask the patient whether they have diplopia. Okay. Then I will also do a look for any pretibial myxedema, and ask them to move their heel down their shins and on both the sides, heel shin test, and then a heel tap test. Hitting the examiner's hand repetitively with the forefoot to see if there's anything. Apart from all this, we can also do a genital examination looking for testicular atrophy. Also, we would look for spider leave and other conditions in case there's a chronic liver disease associated with it, any caput medusae, hepatomegaly, ascites, any of these conditions as well, in case it was. So the DDs are benign essential tremor. We have alcohol related, any cerebellar disease, Parkinson's, drug induced, hyperthyroidism. I guess these are the main ones.